Hello, my name is Jessica Pokuanani. I am a minimally invasive surgeon at UCSF, and I'm here to talk about our SLS highlights from MIS Week 2017, Day 3. Starting with our first plenary session, Dr. Guy Arangio talked about the economics of MIS. And he first went through a really good perspective of the history of our U.S. healthcare system and how it's changed over time, defining what quality is and how it's been measured within our healthcare system, and discussed about how much time and effort we spend as healthcare providers to measure these quality measures, giving an estimate of about 15.4 billion per year that we spend in order to prove that we deserve what we get paid for. And it's this billion-dollar investment that may have caused a burden for physicians and want them to move more towards the national healthcare system in the future. Looking forward, we can look at MIPS adjustment payments and see how these might change based on how much we're able to prove that we provide quality of care. And in summary, he's asked, is national health care the answer? But really, since 1935, the government has been doing multiple different pushes to move from a fee-for-service system to a single-payer system. In 2010, the ACA forced physicians to integrate, and what this has meant for us is that we have to really define what quality and value are and an economic tool to modify physician behaviors. And this extra burden might force physicians to move toward a national health care service. Next, Dr. Michael Stark talked about global health in terms of surgery and looking at the African surgical renaissance. Some of the things that he identified as being barriers are the tradition that's been established by the involvement of many European countries throughout sub-Saharan Africa. He looked at some of the limitations in resources and the absence of standardization of surgical methods across African countries, and talked about some of his efforts through surgical workshops and an all-African surgical database to help standardize the care that patients receive. Moving on, we looked at the award for the best poster presentation. This is a great presentation about the congenital uterine, cervical, and vaginal malformations. And Dr. Xuan Jing and Dr. Guan Nang talked about their first 35 cases of fixing these malformations. They gave us a good example of the two types of malformations and how those surgeries are different. And their study was really unique in that they were able to show that uterovaginal anastomosis can be performed laparoscopically and show that they even had a successful pregnancy out of one of these surgeries. And for our next presentation, Dr. Roberto Gallardo looked at mini laparoscopy and how it's been changing over time. He talked about the goal being making surgery less painful, and the conclusions from his talk are that mini laparoscopy is safe and feasible, and several advantages, including being a simple technique, allowing for triangulation, a critical view of safety, and improved visualization. It's precise, and there's a lot of dexterity involved in it, and it may cause less pain and side effects for patients. Dr. Raimundo talked about the approach to extensive colorectal and genital urinary deep invasive endometriosis. He really promoted a standardized approach, always starting with the ureteral lysis, next followed by opening up the perirectal space with the goal of centralizing the disease, followed by identification of the hypogastric nerve, and finally opening up the rectovaginal space. He also talked about the approach when you look at colorectal disease and described his very unique technique of double circular sigmoid resection. For genital urinary disease, he reminded us to remember to treat the myometrial disease that might be along the lower uterine segment, in addition to bladder lesions. He talked about ureteral dilation using a double J balloon, and that we should avoid ureteral reimplantation if possible. So his mantras were systemization, centralization, and do not start approaching the lesion until you've standardized your approach. This is a good demonstration of his surgical dissection, reminding us of our anatomy that we should dissect out with our major endometriosis surgeries. And this last diagram is looking at his double resection. Doctors Lowell and Pan talked about a humanistic approach to MRKH syndrome. He reviewed the history of the procedure and how he evolved from creation of neovaginas using the bowel to using peritoneum. And he has had a good amount of success with this new approach.